Now it's my pleasure to introduce Professor Goulet, Olivier Goulet, who's a professor of pediatric at the Necker Infant Malade Hospital in Paris, France. Professor Goulet is quite an achiever. He has masters in biochemistry, masters in human genetics, masters in human biology, and today he's going to talk to us about short bowel syndrome. Please welcome Professor Goulet.
Thank you very much, and it's really a great pleasure to be your guest and this beautiful and very interesting country. It's really fascinating. It's my second time in Dubai, and I enjoy very much. And I enjoy very much also to meet so many kind and distinguished colleagues. And my talk today will be focused on short bowel syndrome. Short bowel syndrome is a very special situation, and I would like to separate my talk in 4 parts. First, some focus and reminding about the intestinal adaptation, the factor influencing the outcome in short bowel syndrome, the IFALD, which is intestinal failure associated liver disease, which is a limiting factor in adaptation, and finally, just a few words about global strategy of medical management. What is intestinal adaptation? Intestinal adaptation is a process which is able to allow the gut to adapt. After extensive intestinal resection, the rate and extent of adaptative hyperplasia of residual bowel determines the rate and extent of recovery, as well as the duration of the necessary parenteral nutrition. And the first point I would like to emphasize is that adaptation is a physiological process. The cause of resection are very classical, and unfortunately, the leading cause remain necrotizing enterocolitis. The second, according to the series, is gastroschisis, atresia, midgut volvulus, and in some series, there is a resection for total intestinal aganglionosis. The consequences are numerous, according to the length of bowel resected, to the anatomy which is left or not, including the ileocecal valve, the terminal ileum, that change the prognosis and the duration of parenteral nutrition dependency. And we use today to classify the short bowel patient in 3 groups. The type 1, which is the worst, with short gut syndrome, but no colon, because either the colon was removed or the colon is excluded because of enterostomy. The second form is in case the jejunum is anastomosed to the colon, which miss the ileocecal valve and the ileocecal break. And the third, which is the easiest with the best prognosis, is when both part of the jejunum and part of the ileum, together with the anterior colon and the valve, are preserved. And of course, the prognosis is also dependent on the total length of remaining small intestine. I would like to underline that the small bowel length is highly dependent on the growth of the child. That means that early life is crucial. That is the length of the infant, and that is the length of the bowel. And there is a close correlation with a huge and a rapid growth of the gut during the first 2 years of life. That means early life is very crucial for the process of adaptation. Adaptation is based on both the growth in length, but also the growth in diameter and intestinal thickness. together with the growth on the level of the mucosa, with what we call intestinal mucosa hyperplasia. That means that the number of cells per unit of bowel length is increasing. Altogether, length, diameter, and villous height may achieve sufficient absorptive surface to be autonomous, meaning weaning from parenteral nutrition. The process of adaptation is under the dependence of many factors. First, the systemic factors, including peptides such as the enteroglucagon peptide, the PYY, the neurotensin, etc., but also the IGF-1. But it's dependent also on luminal factor and especially EGF, epidermal growth factor. And epidermal growth factor is released from the salivary gland, the pancreatic gland, and is very, very useful as a trophic factors. The third player is the colon. It plays a major role by reducing time for parenteral nutrition weaning, by improving diet energy salvage, and thanks to hyperplasia of the colonic mucosa. That means it's a double role, the role of the intestinal microbiota and the role of growth factors. And that is very well established now. That is an example which is very interesting. Here you see the small intestinal length, and here you see the fecal energy loss. And all the patients receive more or less the same. And those without colon had the highest fecal energy loss. And those with the colon preserved has a much lower fecal energy loss, meaning that the colon is able to salvage energy, which is very, very important. And this role is also the daily role of our healthy colon. And during the gut adaptation, also the morphology of the colonic mucosa changed. And my colleague Francesca Joly has shown that and published this result, showing that if you compare the crypt size and the epithelial cell number, comparing short bowel syndrome and control, there is a significant difference in both crypt size and number of cells. Interestingly, this work was showing that butyrate is a short-chain fatty acid that is produced by the intestinal microbiota from the metabolism of carbohydrate. And butyrate is one of the most important fuel for the colonic mucosa and the colonna site. And interestingly, by increasing the concentration of butyrate, you may achieve increased villous 8, and also you increase the plasma GLP-2. That means there is a link between the microbiota, the butyrate production, the GLP-2 release, and the growth of the mucosa. And it's a sufficient reason to preserve the intestinal microbiota in short bowel syndrome. And I do consider that the intestinal microbiota may be very helpful in this process by salving energy and also by producing factors that enhance the production of GLP-2. And finally, the aims of management of short bowel syndrome is to maintain growth, which is a priority as a pediatrician, and we have to preserve growth and the development of the child. And we have to establish as soon as possible oral or enteral nutrition, encouraging intestinal adaptation by respecting physiology, and of course preventing and treating complications of parenteral nutrition, including sepsis, thrombosis, liver disease, bone disease, etc., etc. And the nutritional support aims as a parenteral nutrition therapy to provide nutritional requirements for normal growth and development while the bowel undergoes adaptation necessary for the transition to an enterally based diet. But one of the second message this morning is to perform what I call individualized strategy. Each child is different in terms of diagnosis, in terms of bowel length, in terms of bowel dilatation, in terms, etc., etc. And we have to adapt our strategy to the infants, not to adapt the infants to our strategy. And individualized strategy is mandatory because there is many differences between patients. Underlying cause of bowel resection, anatomy of the bowel and bowel length, the number of surgical procedures, the motility of the remnant intestine, and adapting strategy, but respect physiology. And indeed, in our experience, what we do prefer is to combine parenteral nutrition that maintain optimal nutritional status, avoid gut overload. We perform early cyclical parenteral nutrition. We try to prevent complication, and we manage most patients at home. And we combine with oral feeding because we do consider that it's much more physiological. There is a release of EGF from the salivary gland promoted by oral feeding. There is also what I call the self-regulation of intake instead of pushy tube feeding that improve also digestive secretion and that prevent eating disorder. But we try also to combine with tube feeding. But be careful, tube feeding is much less physiological, cause eating disorder. By performing continuous tube feeding, you induce permanent hyperinsulinism, but indeed, tube feeding improve intestinal absorption. But our best option is to combine oral and bolus tube feeding. And again, adapting to the child and not adapting the child to our practice. We do consider, and we published recently in Clinical Nutrition, that the most physiological is oral, the most logical is based on hydrolysate, the most experienced is also hydrolysate, and as soon as it is possible, the most diversified, adding to the diet fiber. And I don't know exactly what is available in your country, but I have seen and read a tendency to propose the amino acid formula for managing short bowel patients. We do consider for most in Europe that the combination of LCT-MCT in a protein hydrolysate is much better than to provide only 3 amino acids. Indeed, but I have no time to go ahead in that direction, amino acid, 3 amino acid as much less well absorbed on the level of the intestinal mucosa and the transporter than the D and 3 peptide. In addition, the cost of these products is much higher than the cost of protein hydrolysate. What are the factors influencing outcome? The time of parenteral nutrition weaning include, of course, the anatomic factor, length, ileocecal valve, colon, ileostomy, etc. And there are many, many references in the literature, but few very large cohorts. Today, nowadays, there is only 4 very important cohorts published. And in this cohort coming from California, UCLA, you can see that the percentage of survival is highly dependent on cholestasis occurrence and as primary anastomosis or not. And on the right side, there is a relationship between the time for parenteral nutrition weaning and the small bowel length, as well as the ileocecal valve. In our experience, we published a large series involving 89 patients with 90% survival. And we have seen that the best option is to have the ileocecal valve preserved and to have a length of bowel between 40 and 80. And the worst situation is by having less than 40 centimeters without the valve. That means that in that option, after 4 years, there is 60% of the infants or children that remain on parenteral nutrition. And that explains that in our cohort of home parenteral nutrition between 2001 and 10, the largest group is represented by short bowel syndrome. But as you can see, most of these patients are weaning off parenteral nutrition. Some are on ongoing parenteral nutrition, and very, very few required transplantation, and none in that survey, none died. And those who were transplanted were extreme short bowel syndrome or total intestinal aganglionosis. And by using a Cox model, we have seen that there is a relationship between the daily intake in lipid and the liver disease, and the catheter-related sepsis rate and the liver disease, as well as the proportion of parenteral nutrition to achieve RDA. And the use of the digestive tract and prevention of sepsis are key factors for preventing liver disease. What about those who remain on parenteral nutrition? And there is several options. Most of the patients can be definitively weaned from parenteral nutrition. 15% require recurrent nutritional support, and 12% remain with partial intestinal failure. And in those patients, we have proposed hormonal treatment, non-transplant surgery, or intestinal transplantation. And indeed, the hormonal intervention are based today on growth hormone or IGF-1. There is no data currently available in children with GLP-2, and there is only one trial which is totally unsuccessful using epidermal growth factor. And we have published a trial involving 8 children receiving during 12 weeks the recombinant human growth hormone at the level of 0.4 intestinal unit per kilo per day. And what we have seen after 3 months an increase in the fat absorption rate, increase in energy absorption rate, and increase in oral intake. And on the level of the plasma, we have seen an increase in IGF-1 level, an increase in plasma citrulline, with a drop to the baseline after 12 months from the growth hormone discontinuation. That means that as much you give growth hormone and as much you give long time, there is an effect. And growth hormone is today available in our practice. That is a single trial reporting an effect of GLP-2 in adult patients, showing a reduced over time, a reduced parenteral nutrition needs. And whatever the dose you use, 0.05 milligram per kilo per day or 0.1, the effect is more or less the same. There is not a dose-dependent effect. This trial with EGF is not really relevant, involving only 5 patients without any significant change. Intestinal failure-associated liver disease is one of the most important causes of death in SBS patients, and as reported by this series of the Toronto group in Canada. And we know very well today what are the factors involving liver disease: the continuous parenteral nutrition infusion, excessive glucose intake, unadapted amino acid intake, unadapted or excessive lipid intake, unadapted or excessive iron intake, and manganese, aluminum overload. But most of the time, this is unadapted practice that provide intestinal failure associated liver disease, especially excessive glucose intake together with continuous parenteral nutrition infusion, with continuous tube feeding, inadequate lipid intake. And that lead to excessive fat body mass, to poor growth velocity, and onset of liver disease. But the most important factor are related to the sepsis, and either the catheter-related sepsis or the bacterial overgrowth. And the sepsis related to catheter have been shown, and in this series we reported in 2007, is clearly related to the early onset of sepsis and to the number of gram-negative sepsis. And indeed, for those who are experienced with short bowel syndrome, that is a figure which is very common both in intestinal atresia or gastroschisis, with poor motility loop, with bacterial overgrowth, mucosal injury, and bacterial translocation. And I would like to show you how it works. Intraluminal bacterial overgrowth is due to intestinal stasis combined with nutrients delivery, and especially during tube feeding, because continuous tube feeding impair the intestinal motility and impair the bacterial clearance in the gut. If you combine this, you achieve a child with nausea, vomiting, abdominal pain, abdominal distension, and rare or abundant stool. But the most important mechanism is bacterial overgrowth, leading on this side to mucosal injury, villous atrophy, malabsorption, increased permeability, and finally food allergy, eating disorder, and poor growth. And on this side, which is the worst, translocation, enterotoxin release, gram-negative sepsis, and portal inflammation, cholestasis, fibrosis, and cirrhosis. And recently was published several review papers and very interesting experimental work showing a direct link in terms of reducing bile flow and inducing inflammation within the portal space following translocation. And this work was published this year in Hepatology, and it's an intestinal model in the mouse showing that if you combine parenteral nutrition, including lipid, and mucosal injury by DSS, which is toxic for the mucosa, you increase the permeability. And by increasing the intestinal permeability, you increase within the portal space the IL-6, TNF-alpha, and IL-1. That means there is a direct link between intestinal bacterial overgrowth, intestinal permeability, and portal inflammation. And this work was also published this year in Journal of Hepatology, showing that intestinal decontamination, which is not the good treatment for this situation, but it's an experimental model, is able to decrease, to inhibit the TLR4 dependent fibronectin mediated crosstalk between stellate cell and endothelial cell in liver fibrosis in mice, making again another demonstration of the link between the intraluminal content, the intestinal permeability, the translocation, and the portal inflammation. That means that in our daily practice, we have to focus on the particular high-risk situation. Those premature baby and young infant with neck or gastroschisis, with protracted bowel rest and intestinal stasis, with bacterial overgrowth and gram-negative sepsis, but also recurrent catheter-related sepsis, and unadapted and continuous parenteral nutrition. And you can believe me, unfortunately, some patients with very severe end-stage liver disease are referred to us because of lack of prevention of the onset of liver disease. And in that setting, microbiological approach is, to my opinion, hazardous, because first, you kill the intestinal microbiota, and secondly, you may improve the risk of bacterial selection, which is very, very difficult management afterward. And we do prefer to consider the distension as assessed by the biome follow-through, and to perform surgery in terms of bowel tapering and lengthening by two techniques. And the techniques are possible because there is a natural physiological dilatation of the bowel, which is a normal process that can be increased by the obstruction and the poor motility, and leading to bacterial overgrowth again. And in case of long dilated segment, there is an indication of tapering, and short dilated segment, there is an indication for lengthening and tapering. And there is two techniques for that, the lengthening and the serial transverse enteroplasty, which are surgical procedure as called non-transplant surgery. And as you can see, you make from one dilated tube two thinner tube, and you make the antegrade anastomosis. And that is another technique introduced by Dr. Kim from Harvard University, showing that by cutting on the regular interval the gut, you may reduce the diameter and increase the length. And the group of Toronto again report, especially in those patients with atresia, neck, or gastroschisis, representing 85% of the patients, they perform this serial transverse enteroplasty procedure. And what they have shown, very interesting, the stool frequency decreased progressively within 6 months. The bowel caliber decreased and re-increased and stabilized after 3 to 5 years. The median transit time increased and stabilized thereafter. And the stool consistency increased also. But one of the most important signs and result, to my opinion, is the increase in the citrulline. Citrulline is a plasma marker of bowel trophicity. As much the villi are high, as much the citrulline plasma level are high. And during the process of bacterial overgrowth, there is mucosal injury, villous atrophy, and decreased citrulline. And as you can see, by reducing the intestinal bacterial overgrowth, you increase the villous 8 and you improve the intestinal absorption as assessed by Dexilose. You reduce the alpha-1 antitrypsin clearance and you decrease the fecal fat excretion. That means that this procedure is very interesting and should be done by any pediatric surgeon, experienced pediatric surgeon. And that is to show you the dependence on parenteral nutrition over time. That means that, to my opinion again, the microbiota may be very beneficial in terms of promoting intestinal autonomy by promoting especially short-chain fatty acid and GLP-2, but may be very, very deleterious in case of bacterial overgrowth. And we have to find the balance in between to preserve as much the physiology. And finally, to my opinion again, the global strategy is really based on the close collaboration between surgeon and pediatric gastroenterologist. And as pediatric GI, I have been educated very close to the surgeon. And we share a lot of issues regarding the neonatal period, non-transplant surgery, and of course, intestinal transplantation. And that is very, very important today to have this in mind. And how avoiding liver disease? 5 minutes? 2 minutes? 5 minutes, okay. How avoiding liver disease? By performing the best parenteral nutrition you can with a balanced protein energy supply, the use of pediatric amino acid solution, the use of fish oil-based lipid emulsion, early cyclical parenteral nutrition, but also by preventing infection, bacterial overgrowth, by improving digestive function, and by promoting oral feeding. This child referred to us with severe liver disease, and he was referred for performing combined intestinal and liver transplantation. And as many others, we managed this child by just adapting parenteral nutrition and by fighting against bacterial overgrowth, and especially by performing step or lengthening, and by promoting oral feeding. And the example of this child was referred here. And after all the management and manipulation, the growth curve totally changed with catch-up growth both in body weight and length, and this patient finally first survived and secondly was never transplanted. And we have published 2 years ago this study showing the beneficial effect of the new generation of lipid emulsion containing a mixture of soybean oil, medium chain triglyceride, olive, and fish oil. And as you can see in this trial, after 1 month, the bilirubin tend to decrease in patients receiving the fish oil base and tend to increase in the intralipid group, and the difference was finally significant after 1 month. And we do consider that the whole generation of lipid emulsion that was based only on soybean oil emulsion are now belonging to the past. And the new one has beneficial effect to provide EPA and DHA, which is excellent for the neonatal brain, and also to decrease inflammation, to increase antioxidant activity, to decrease the phytosterol, which is toxic for the liver, and increase the bile flow. And all the results currently available in the literature tell the same. And we also need to have a group of experts with close relation between pediatric gastroenterology and nutrition and surgeon. And we have achieved this goal, and we have promoted some recommendation in terms of the globalization of the management of those patients with intestinal failure. And thanks to that and the use of fish oil, it is very interesting to see that the need for intestinal transplantation in children dropped totally during the last 5 years thanks to this better global management and the use of fish oil-based emulsion. And as you can see, the proportion of the transplant involving both intestine and liver decreased dramatically and fortunately from the beginning of our experience with intestinal transplantation and now, which is a demonstration that better management may save life. And finally, I would like to conclude in telling you that short bowel syndrome is clearly a double challenge for the bowel adaptation and the child growth. We have to respect physiology of adaptation, to use as much the gastrointestinal tract, to preserve the colon, and to perform long-term nutritional support if needed for achieving optimal growth and genetic target size achievement. Thank you for your kind attention.